So good morning and thank you for the invitation. So a few words about this study. So as every good research question, it starts when we have argument in our breast cancer unit meeting and we argue what should we do. One say, let's send oncotype. The other said, let's give chemo, let's do only endocrine therapy. And this question actually have been raised while I was still in Rambam 3 years ago when he had a patient. She was, if I remember correctly, 60 years old, and she had a second primary breast cancer. And we were thinking, should we send another oncotype or not? And this is how all this study actually was started. My disclosures. So we're all familiar with the Clalit registry, and this is where we take the data from. And when we look in the Taylor X results, we see that out of almost 10,000 patients, 327 had local regional recurrences and ipsilateral or contralateral breast cancer. And what we wanted to see is to explore the data we have from Israel, from the Clalit registry, and to see, can we then identify the patient who had second primary breast cancer from this registry? And do we have any differences in clinical, pathological, or recurrence score characteristics between the first and second primary breast cancer? Can the recurrence score predict clinical outcome after the second primary breast cancer? I think this is the largest question for all of us. Should we even send a second oncotype for the same patient? So what did we do? The inclusion criteria to choose those patients, they had to have estrogen receptor positive breast cancer. They were tested in the Clalit between 2006 and 2020, and they need to have two recurrence score tests performed at least 1 year apart, because we want to separate two different cancers, and they could have N0, N1 MYC, or N1 when they're first tested. The second recurrence cases were considered second primary breast cancer because the assay is not supposed to be done again for local regional recurrence. So the group that we could compare was first the cohort described in Stemmer manuscript, the large oncotype Clalit recurrence score group from the database. And we also did an analysis with match control in order to see is it still prognostic, and we could use and choose patient and do match control from this database in a 1-to-3 ratio, and you'll see it later. And what we used for the propensity score were gender, nodal status, recurrence score result, age, tumor size, and grade related to the second primary breast cancer. The data source was from the Oncotest, gave us the data about the recurrence score and tumor characteristics, and all the other data was about treatments, recurrences, and death was taken from the medical records of those patients. And you can see here the statistical considerations. So who are those patients? So we could take, again, from the database, as Elior just mentioned, we have a long-term database from 2006 and 2020, almost more than 11,000 tests, and we could find 60 patients that meet the eligibility criteria. That means that we found 60 patients that had two tests with 1 year apart. All were female, and the median time between the second and the first recurrence score was 5 years. Location of the second primary, so in almost 70% it was in the same breast, and 30% it was in the contralateral breast. You can see here all the characteristics of those patients and tumor. You can see the study group in the left side for the N0 and the other side the N1. You can see that the study group was pretty similar to the general population of the all Clalit registry, except for age. You see it highlighted in red. So the patient that had a second primary were younger, but all the rest was about, like tumor size category, grade, were similar of this group and all the cohort. You can see also here that also ductal versus lobular and also nodal status, all were similar in the small group of patients that had second primary and the general cohort. Here you can see that the patient in our group, the 60 patients that we found, had similar result in the first breast cancer to the general population. You can see it's also by the median that was similar, 16.5 versus 19, and also by the categories of the recurrence score were also pretty similar. And now we look into this group alone without comparison to the all Clalit registry. And you can see here that most of the tumor and patient characteristics are pretty similar between the first primary and the second primary, except for age, which makes sense because they're older when they develop the second primary, and the median was 5 years. But if you see the tumor size and the grade and the histological type and nodal status, all were similar. You can see maybe that patient had a bit smaller tumors and maybe less node positive, but that makes sense because patient after the first tumor, usually we have a very good follow-up, the surgeon, the medical oncologist, we see them at least every 6 months and we do good imaging, so that makes sense. And you can see in this graph, this is every patient, individual patient, you can see patient numbers in the bottom, and you can see that the first recurrence score is in blue and the second recurrence score is in orange. And you can see it visually very well that most of the patients had higher score in the second primary if you compare it to the first primary. You can see that quarter of the patient had lower score and the majority of the patient had higher score. And the differences are have a very wide range. And I think this is one of the most interesting found that we saw, that in the second recurrence score, when you compare to the first one, you can see that also the median recurrence score was significantly higher. 23 was in the second and 17 in the first. And also when you see the proportion of the recurrence score groups, you can see that while in the first recurrence score, only 50% had 26 and above, in the second primary, 40% had 26 and above, which means we might recommend to give chemotherapy for those patients. I think this is very striking and an interesting finding. I know every time I talk about this study, everyone asks me what the patient got. So here it is. Okay, I put it as a slide. So you can see that more than half of them received only endocrine therapy. And you can see that in the first breast cancer, around 15% got chemo, and while in the second, almost 40%. And that makes sense because 40%, as I showed you, had 26 and above. And here is the analysis of the match control that we done. And you can see here that we had 56 patients with good data on them. And we found the controls, match controls for each patient, 3 controls. As I mentioned before, the controls were by the gender, the tumor size, grade, of course, the recurrence score. And you can see here in the red line of our small cohort that those patients, although it's a match control also to the recurrence score, they still do worse. So second primary, and it makes sense, but here we show it, is doing worse. One of the things that we noticed that patients in the controls received more chemotherapy, but still, when we did a separate analysis and took only the patient that didn't receive chemotherapy, we still saw this separation of the graph, and I think it's kind of confirmed that the patient with second primary do worse, although in the same recurrence score groups. And now I'm trying to answer to, I think, the largest question that we had. Should we still use, is it still prognostic? And you can see here that we have a separation of the curves in 26. You see it's not significant, and I think this very small number, it's hard to show as significant. But I think it's still brainstorming and still maybe give us a clue that it can still be prognostic in this cohort. And we also put here, this is a second question all the time get, what those patients got. So we have only 5 recurrences, and those are the patients. You can see here, they're pretty young. You can see their age in the left side. And you can see visually at least that the second recurrence score was higher, and also the time to distant metastasis, that was our endpoint, you can see that it has a pretty wide range. The limitation of our study, so it's a non-randomized retrospective data. There is some selection bias for which patient the physicians submit a second recurrence score testing, small number of patients in event, and also regarding the diagnosis of second breast cancer in the same breast. We don't really know if it's local regional or not, but this is the way the test should not be submitted for local regional. And also another issue is that we don't have BRCA status. So to conclude, our conclusion, in the first diagnosis patient that have second primary, they don't differ in any way from the general population except for their young age. Second primary breast cancer was characterized by higher recurrence score result, but no other difference, pathological or clinical features. Patients with second primary have poor clinical outcomes when matched to controls, and I think further study is warranted to find and to elude the potential prognostic utility of the recurrence score after second primary breast cancer. The study was small to provide more insight. We really did every analysis that's possible. And another thing to say, we all familiar with the Clalit study that had a very small number of estrogen receptor positive with isolated local regional recurrence, and they were randomized to chemo or not. And actually the bottom line of the study, with all the limitation, because it didn't get to the accrual they were supposed to get, I think this is one of the evidence that we use not to give chemotherapy for breast cancer recurrence. And I really want to thank, I thought Dr. Rizzo will be here today. She was the one that encouraged me to ask this question, and all the other investigators, and of course to Avital, who helped me with all those slides. Thank you so much.
You do a separation of outcome of women who recurred while on hormonal therapy versus women who recurred while off hormonal therapy?
So we did this analysis. We didn't find any differences, but I have to say it's very small numbers, so it's really hard to conclude any good answer for that.
Thank you.